Thank you very much, and good afternoon. I also want to thank Jim for inviting me here today, and it's my pleasure and my honor to be able to speak with such luminaries in the field of neuroendocrine tumor, and I've learned a lot already this morning. My major interest had always been in...
I want to stop you for 1 second. I need to bring this up. It's got to come way up higher for live sound reinforcement. He's going to have feedback the whole time, and that's not a good thing. That's good.
Okay. In the development of experimental therapies from my laboratory, where we develop different treatments for brain tumors, pancreatic cancer, and now very heavily into neuroendocrine tumors. And the reason we got into this field was because pancreatic adenocarcinomas, which everyone knows is one of the worst malignancies that there is, a lot of patients were referred to me that when we reviewed their pathology, it was not pancreatic adenocarcinoma, it was a neuroendocrine tumor because special stains were not properly done. And we didn't know what to do with these patients, and we decided let's start studying this disease since it's one that's really an orphaned disease that nobody has put much time and effort into. And so that's how we essentially got into it. I also want to tell you that I'm originally from New Jersey. I know my itinerary is from all over the United States, but some good things actually do come out of Atlantic City, which is where I was born, besides Boardwalk Empire. Okay, in the background of this, of chemotherapy for this disease, there were many studies done by a guy named Mortel at the Mayo Clinic who reported very, very high response rates initially. That was with two drugs, cisplatin and etoposide. But the problem with those initial studies was, number one, they weren't well done. Number two, most of the tumors were not truly neuroendocrine tumors, well differentiated with a low Ki-67 growth rate, but instead they were fast-growing neuroendocrine small cells. And those have a high response rate eventually. Also, they were using, surprisingly, symptomatic relief as a response criteria and also physical exam, which many times can be completely, can fool you into thinking a patient has had shrinkage, and you don't, until you actually see it on a CAT scan or MRI, you realize the tumor has not shrunk. So the actual response rates when they re-evaluated those initial studies was less than 10%. The regimens that many of you probably have heard, or some of you have actually received, which in many aspects are somewhat barbaric because the way they're developed, unfortunately, by a lot of, I think the early medical oncology field has been empirically done. In other words, they just take drugs and put them together without understanding the pharmacology of the drugs or the molecular aspects of how best to put drugs together. There's really a true science to that. And these combinations like streptozocin, 5-FU, streptozocin, doxorubicin, actually had response rates that were very low, less than 20%, and they were extraordinarily toxic. Streptozocin can produce diabetes and has a lot of kidney toxicity. Doxorubicin produces a lot of heart problems and heart failure. So two people did retrospective analyses of many of the studies that were done at their institution, Memorial Sloan Kettering Cancer Center, and also Dr. McCullum reported in their series that the response rate in true PNETs, pancreatic neuroendocrines, it was less than 10%. And carcinoids were even worse. In fact, of all the different types of neuroendocrine tumors that Dr. Warner went through, it's the carcinoids that have the lowest response rates to chemotherapy. So the question we asked, why are carcinoids and neuroendocrine tumors so resistant to chemotherapy? Well, one thing that we know is that there are two different systems of DNA repair, major systems of DNA repair. One is called the O6A-GAT, which stands for alkyl guanyl alkyl transferase, and then there's this mismatch repair. And both of those work many times together to repair DNA damage. The average cell in your body gets 10,000 DNA hits a day just from normal metabolism, and those have to be repaired in each cell, the trillions of cells that you each have in your body. Dr. Kulke up at Dana-Farber found that in neuroendocrine tumors, the AGAT levels are actually very low. So AGAT does not play a major role in DNA repair in the neuroendocrine tumors. And this actually is quite important because this led us to thinking, like, what other mechanisms could we find? And basically, in the bottom of the slide, it shows that we analyzed a lot of these tumors and found that they had normal P53, which is a very important drug resistance producing protein. And the growth fraction of all of these tumors was extraordinarily low. Now, as an oncologist, it's very important, all of us know in oncology that when you give chemotherapy, you're only really killing growing cells. When you induce this mechanism of cell death, there are multiple mechanisms of cell death in a cell. One of them is called apoptosis, which literally means leaves falling off a tree, that was termed by Hippocrates himself 3,500 years ago. And there's another mechanism called necrosis, which describes a lot of what the interventional radiologists induce with their drugs, high-dose drugs, when they embolize lesions. Anyway, the important thing with chemotherapy, most of what we do is try to induce the cell into apoptosis, which is cell suicide. And the cells do not undergo this form of cell death for reasons that are not clear, but I think one of the major reasons, we felt one of the major reasons why they're so resistant is because they're not growing. In other words, if you have a Ki-67 of 2%, that means 98% of your cells are resting in a resting phase of the cell cycle, and they're not growing, and that means they will not be killed by chemotherapy. So this is called cytokinetic growth rate resistance, which was an old term 40 years ago, termed by a guy named Skipper, that described drug resistance in tumors, that many times fast-growing tumors can be more responsive to chemotherapy unless they've got lots of mechanisms of resistance. There are not many mechanisms of resistance in neuroendocrine tumors, at least that we could find, but they grow so slowly they don't die. They're not in growth phase when the chemotherapy is given. And we felt that was a very important clue. Thus, what can you do to kill a tumor that's not growing? And this is actually an important question for a lot of various malignancies in humans. Regular chemotherapy that is cell cycle or cell phase specific does not work generally. However, there is a group called the lipophilic alkylators, which many of you know because of Temodar, that's a major one, BCNU, CCNU, Thiotepa, and so on. These lipophilic alkylators kill cells when they're resting. And long-term exposure to an antimetabolite, such as 5-FU, which is also in the oral form known as Zolota or capecitabine. Again, some of you know of that drug as well. Ionizing radiation can do it, and hormones can do it, but there's not much else that can truly kill non-growing cells if you want to induce this form of cell death called apoptosis. However, you can induce necrosis with high-dose chemotherapy in a localized area, such as in chemoembolization, that can kill cells in a different mechanisms that's very non-specific. It kills normal cells as well as malignant cells, and is very different than apoptosis. So we went to my laboratory and looked at these drugs very simply and found combinations or sequencing that could give us a hint as how to give these two drugs together. In other words, continuous exposure 5-FU and temozolomide. And you can see on the left, the 5-FU at very high concentrations doesn't kill many of the cells, 15%. Temozolomide only kills 19%. We go to the right-hand side of the slide. The temozolomide given first, followed by 5-FU, kills 33% of the cells, and then the 5-FU given at the same time as temozolomide also kills the same proximate number. In other words, it's additive. If you take the 5-FU and temozolomide on the left-hand side, and add them together, they equal the two on the right. But if you give 5-FU first for a number of days and then expose the cells to Temodar, you get synergistic cell kill. And that's a very important thing. Basically, everything that we've developed in my lab has been based on biochemical synergy. We developed a regimen called GTX for pancreatic cancer that when we published our current paper, will show the highest response rates and survival rates in the world for adenocarcinoma metastatic to the liver of the pancreas. And that's based on synergistic combinations of drugs that do not require high doses, but they're developed in the laboratory first, as opposed to just giving them without order or thought in humans. So if 5-FU is given first and then temozolomide, you end up getting this synergy. And what does 5-FU do? Well, there are 3 things that 5-FU does, and I'm just going to talk about the one that's most important. It takes this base pair called deoxyuridine monophosphate, DUMP, on the left, and converts it through this enzyme, thymidylate synthase, to deoxythymidine monophosphate. So DUMP goes to THUMP. And what THUMP is thymidine. So the cells die because they lack thymidine. And this was a clue as to what was going on, that the pre-treatment with 5-FU was depleting thymidine. And I'll try to bring this all together to show you that if you don't have thymidine, then mismatch repair killing is greatly accentuated. So this is a picture of mismatch repair, the mechanism of drug resistance that occurs in drug tumors such as neuroendocrine. I'm sorry about this, the thing keeps going back. And basically on the top it says GCH3, so the guanine is methylated by temodar. Temodar adds a methyl group to the DNA, and the DNA tries to repair it, and when it gets repaired, as it goes to the right, where C replaced with T, it replaces that thymidine with cytosine, and it goes around to the bottom, and there's a break there in the DNA. And then the cytosine is added again. So the mismatch repair enzymes are taking this methylated guanine and looking at it as adenosine, and that's why adenosine should not be paired to cytosine, but it's actually paired to thymidine. And that another set of enzymes comes by and says, this is not correct, let's take the thymidine out. And then the other mismatch repair enzymes on the left will come in and repair it. So this goes through this futile cyclic repair. And essentially it continues until you run out of thymidine. When you run out of thymidine, you have a break in the DNA, and that is the most potent stimulus for apoptosis. So we thought, let's deplete thymidine faster by using 5-FU. Very simple. Once you know what you're doing, I guess. So prior long-term exposure to 5-FU depletes the thymidine, and then when you add the temodar, after the thymidine is depleted, you accentuate and accelerate killing, or apoptosis. So essentially this whole pathway is improved and increased because you're depleting the thymidine. And this concept will work with any tumor. Temodar is used, besides in neuroendocrine tumors, it's the major drug for melanoma. It's the major drug for gliomas. And you can use this concept, biochemical synergistic concept, to improve, perhaps to improve responses to temodar in gliomas and melanoma. So we have our first publication that is actually going to be submitted very shortly, but it's already been accepted for publication, amazingly. And it's a conglomeration of different people around the country. In fact, one of them is the surgeon, Dr. Fracker at Penn, who actually contributed a patient. And we have a rule that if you contribute a patient to our studies, we offer authorship for that. So what did that study show? So this was a retrospective CAP-TEM study. I call it CAP-TEM because it's capecitabine and temodar. and sort of like a captain. So that's where that term came from. All patients had metastatic to the liver neuroendocrine tumors. 4 of them were carcinoids and 14 were neuroendocrine tumors. All patients had failed high-dose sandostatin. One of the first things we do with our patients when we're giving them sandostatin, which is a very non-toxic drug, we go up on the dose based on the kinetics of binding of sandostatin to the tumor cells and showing that you can actually increase response rates by going up to 60. Beyond 60, there's no demonstration of improved efficacy. So patients get treated up to 60 milligrams of the sandostatin, and when they fail that, or if they fail that, they then would be treated with the Captem. Our overall response rate in the study was 61%. And the 4 carcinoids I'm pointing out here because of this meeting, one was a woman who had carcinoid to both lobes of her liver and to multiple spots in the intestinal area. And she actually had a complete response, at least by CAT scan, MRI, and a PET scan, which was interestingly positive in her. She had a gallbladder disease in the past, and she went for a gallbladder removal. This was after 8 cycles of Captem, and basically the surgeon was asked to biopsy every spot where there was prior tumor in her liver, even if there was no tumor to be seen, and everything was surgically proven that she had a complete response. So she still remained in complete response for 27 months off of all therapy, including sandostatin, and the tumor did come back eventually. One other case was a partial responder, one had stable disease, and one had progressive disease. The only toxicity with this regimen, interestingly, was 11% had grade 3 thrombocytopenia, but no other toxicities. It's extremely well tolerated, and there are many patients in this room who are on Captem right now. When we made this finding, I wasn't sure what to do about it or how I could get these patients outside of just picking them up out of pancreatic cancer practice. And I went to 2 of the masters in the field, one of them Dr. Warner at Mount Sinai, and the other one Larry Qualls at the University of South Florida. And I told them about the finding and asked them to please help corroborate our findings by treating patients with Captem to see if they get similar type results. So Dr. Qualls took 30 patients. This was, again, retrospective data, and that's probably one of the greatest problems in this field. Just to go off on a tangent for a second, is that virtually everything is retrospective, even the interventional radiology studies, the chemotherapy studies, and that's a problem because retrospective data is not as rigorous and it's not as believable as a study that's done prospectively in a rigorous trial where everything is kept to a certain standard. Nevertheless, because it is a rare disease and patients many times are not treated for it or not discovered, it remains many times in retrospective studies. So this was a retrospective study which could be termed a criticism. Nevertheless, 30 patients with pancreatic neuroendocrine tumor were treated with Captem, and he was nice enough to put me there as an author. And these are the results. There were no carcinoids in the study. Patients had prior chemotherapy, but had different interventional radiology therapies, and many of the patients had sandostatin. He reported a response rate by RECIST, which is the strict response rate, of 70% and 25% stable disease, which shocked, I think, practically everybody in the field of medical oncology to hear about responses so high. Again, the only toxicity he found was exactly what we had. 11% had lowered platelet counts. That's what thrombocytopenia is. And that was the only toxicity. Those lowered platelet counts had no problems. There were no sequelae to that. They didn't need transfusions. They did not have any bleeding problems. It was just a lowered platelet count. So this looked pretty good so far. So we decided we have to bite the bullet and do a prospective trial It's a phase 2 trial, and it's an investigator-initiated trial that we wrote up. And this is the front page of our protocol. This protocol is actually still going on at Columbia, and we're still accruing patients for this trial. It's been going on for 5 years. But that gives you an idea of how difficult it is to get patients for this trial. The primary objective is to look at the response rates by strict radiographic criteria such as MRI or CAT scan. We do not use octreotide scan to tell us if there's a response or not. And the secondary objectives are listed there. Progression-free survival, that's the amount of time that you spend not progressing, where the tumor has stopped growing or shrinking. We also looked at the toxicities, we looked at biochemical markers, we looked at relief, how well the patients felt from their neuroendocrine tumors, and we also did some laboratory correlates looking at enzyme levels for the O6-AGAT and mismatch repair enzymes, so that we could learn something from the study, at least correlate that. The inclusion criteria are the following. Essentially, anybody with neuroendocrine tumor, that's 3.1.0, was allowed onto the study. The only requirement was that they had to have failed high-dose sandostatin. You could see all the different types, and the very last one here was a surprise, but when we thought about it, that pituitary adenomas and pituitary carcinomas, for which there is no chemotherapy, would be a great treatment, is a neuroendocrine tumor. And especially the anterior pituitary is neuroendocrine, so we thought we should treat this as well. The exclusion criteria I won't go through, but essentially if you've had CAPTEM in one way or another in the past, you were not allowed onto the study. But if you've had the 5-FU given as an intravenous bolus, you were allowed onto study. And this is the way the CAPTEM regimen currently exists. They take essentially a maximum of 2,500 milligrams a day of Xeloda. So that's essentially 2 pills in the morning and 3 pills at night for a total of 2,500. And then that's for 14 days. On day 10, when thymadine's depleted, they get Temodar, and they get 150 milligrams per meter square if they've had prior chemotherapy, and they get 200 milligrams per meter square if they've had no prior chemotherapy. And we give it twice a day. We divide the Temodar dose into twice a day. And why do we do that? And I noticed people around the country are not doing that, and I think it's actually quite important. We published this paper a few years ago with people at University of Pennsylvania and Stanford, showing that if you give Temodar twice a day, you take your dose and you divide it into morning and night dose, you nearly double the response rates in recurrent high-grade brain tumors. And that's with Temodar treatment. And so we felt that that twice-a-day treatment was important. The first dose depletes the enzymes, and the second dose causes the DNA damage. So that's why we give it twice a day. The other reason we give Temodar twice a day is that it's much, much less nauseating to patients to take instead of one big dose. And these are the results. The carcinoids, there were 11 patients, 7 typical, and of those typical, we had 3 out of 7 responses, which was a 43% response rate. One of them was a complete response of a patient, patient with metastatic, they all had metastatic to liver disease, but this patient had a complete response that was proven. And stable disease occurred in 57%. The progression-free survival is a median, which is like an average of 24 months, but it's between 6 and 28 months, and there were no progressive disease. The atypical carcinoids, which some of you may know of, which is a little faster growing, 25% response rates, 75% stable disease, and the progression-free survival is over 2 years. And so if you add all that together, you have a 36% response rate in carcinoids, which is remarkable for a disease that normally doesn't have response rates above 5% with chemotherapy, 64% stable disease, progression-free survival over 2 years, and not one patient has had progressive disease on CAPTEM. For the neuroendocrine tumors, which include all the different types, 30% response rates. This is strict RECIST criteria with intent to treat analysis. 70% stable disease, 22 months progression-free survival, no progressors. And people with pituitary tumors, that is adenomas or adenocarcinomas that have failed radiosurgery, stereotactic radiation, multiple neurosurgical procedures, who are essentially dying because their tumor is pushing against their brainstem and causing them to stop breathing. 3 out of 3 patients had responses. One of those responses was a complete response where the tumor completely came off the brainstem, the pons, and the medulla, and the woman came off a ventilator and is now normal. And that was amazing. That was a very nice discovery there. Our progression-free survival is a little over a year. The toxicity, 4% had low platelets, 4% had low white count, 4% had low white blood cells, but grade 3, which is not that severe. There was 1 grade 4 toxicity, which is bad, which is total CBC was depressed, but there were no need to use growth factors. There were no episodes of sepsis or infections. 1 out of 25 patients developed grade 3 nausea. There was no grade 3 nausea, vomiting, diarrhea, or GI bleeding. The other toxicity was a grade 4 high blood sugar. So no other toxicities occurred in these patients, which is amazing in how non-toxic it is. There were no hospitalizations. There have been no deaths that were from the chemotherapy. And amazingly, their bone marrows are not being wiped out by the Temodar. Temodar typically causes irreversible damage to the bone marrow, but we have people who are on CAPTEM for over 5 years in responding still, who have had no decrease in their blood counts. So for some reason, the Xeloda makes it less toxic. How can we make CAPTEM better was our next question. I'm trying to wrap up everything very quickly. Basically, we tried different small molecule inhibitors. Some of these you've heard this morning, such as Sutent. And there was only one of them which produced biochemical synergy with CAPTEM, and that was Sutent. And basically, it shows on the left here, these graphs. This is looking at toxicity. The cells, 9% die here. If you add temozolomide, or Temodar, and 5-FU, you kill about 22%. If you add Temodar and 5-FU, you kill about 40%. And if you add CAPTEM plus Sutent at low doses, you kill close to 80% of the cells. And what this shows on the right is a depiction of how many fold killing occurs. It's essentially you increase the killing of CAPTEM 3.6-fold by adding low-dose Sutent, not every day like the way the manufacturer wants you to use it, but for only 5 days a month when you're actually taking the Temodar, which is when the synergy would occur. So the summary, the major obstacle we believe is due to growth rates. It's so slow. Sutent has a response rate of shrinkage of 9%. Everolimus has a shrinkage rate of 4%. So these are not panaceas. These drugs produce stable disease. They do not shrink the tumor significantly in pancreatic neuroendocrine tumors, and they don't really work well in carcinoids. This CAPTEM was designed in the laboratory for slow-growing tumors, and then I just have the rest of this is repetitive, but our response rates range from 30 to 60% for neuroendocrine tumors and 36 to 50% for carcinoids, and 100% for pituitary neuroendocrine tumors. So I just want to thank these people listed here, without whom this would not be possible to show, and thank you all for listening.
Thank you, Dr. Klein. Interesting. I'm like, okay, can we find out more?